national nonprofit. We do a lot of things to directly support patients. A number of educational things. We have video series, print materials. We have something called our living room series where you have researchers come and talk, have exchanges with patients. We do a number of things to, directly navigate you. We have 1-800 helpline. We have our Love Match program, which I'm a navigator for, that helps specifically talk about clinical trials and some of these new research advances that we touched on. And we connect people with the community. We have an advocacy day where we take advocates to Washington, D.C. and help them learn how to navigate for issues at home. And also, we have things like our Phone Buddy program where we connect patients to each other over the phone and talk about shared experiences. So, really, there's a lot we can do. You can find us at go2.org, and we just, like to meet you where you are and be a resource along the way.
It's a great resource.
Keep you here.
Questions? Okay, I've got another. So Dr. Rudin, obviously you talked about we've come a long way in small cell lung cancer. Can you talk a little bit about how quality of life will impact treatment decisions and the discussions that patients should be having with their providers?
Yeah, we obviously want patients to live longer. We also want patients to live better, and we really want them to be able to live a full life. I do think one of the limitations and why I'm a little bit of a naysayer about the Forte data that adds chemo into the maintenance is patients get a great response often to the initial chemotherapy induction. And then they finish their 4 cycles of chemotherapy, and that's actually when they're feeling sometimes best because they've actually got less disease, and they're looking forward to not having to continue the adverse effects of chemotherapy, fatigue, nausea. That's a phase of therapy where they're entering into immunotherapy with the hope that the immunotherapy is going to hold the disease in check. To add another chemotherapy on top of that does impact their quality of life. Now, some patients feel like it's worth it, and they want to push forward, and they want that chemotherapy. But I think it's entirely reasonable to save that for down the road. So it's a conversation that patients should have with their clinician about, when do you need a drug holiday? Because people need a break. You can't just keep on these cytotoxics forever. And my feeling is we need better drugs, and I think we have better drugs coming, and maybe less toxic drugs. I'm a big fan of giving people a little bit of a break after induction therapy, because that is a period of time where the quality of life is maybe maximal for these patients. And for some patients, that can last decades. So we want to give them the opportunity to be those patients who have a transformative benefit of immunotherapy, who might not need to continue toxic therapy, forever.
You bring up a good point too, and we often hear that physicians will want to dose reduce or modify, and that scares patients because it's like they don't want to lose out on treatment. Can you maybe help dispel that?
Again, it's a time of sort of shared decision making. I think, and different people have different philosophy about how they want to consider trade-offs in that space. Again, I think quality of life is a really important point. Spending time with the family, not spending time in the oncology suite and in the chemotherapy suite, or in the hospital. And if there are periods of time when they can be free of that, that's really important. If dose reduction can help with that, great. I would say most of our therapies are not super dose dependent. That is, a dose reduction doesn't mean less efficacy. If it means you can continue that therapy with good quality of life, I think that's an important trade-off. And we talked about small cell here, but for non-small cell, I think particularly some of these target inhibitors, we're going to be taking the drug every day. And there are toxicities that oncologists think we describe as tolerable. But for patients, it might not be so tolerable. If you're having diarrhea every day, it becomes problematic. And a dose reduction is a scary thing to consider because you don't want to lose the efficacy, but in most cases, we're already dosing well above the threshold of efficacy. So dose reduction for quality of life is really important. And it is a discussion. We don't do it